I've been asked to talk about how I save limbs in Purpura Fulminans, but I work in London, and what I can do in London may not be possible for you back home. So what I would like to do is to provide you with the evidence of why I do what I do, so that you can go back, make up your own mind about whether this is what you can do as well in your unit. I also want to talk about the pathophysiology of Purpura Fulminans, what the causes are, so that you can then understand why I'm doing certain things in the general field and also with specific therapies. The most common cause of Purpura Fulminans in the UK is from infection, and the most common infection is from meningococcus. But there are also patients who have inherited and acquired abnormalities of the clotting pathway, especially protein C and antithrombin deficiency, that can also develop Purpura Fulminans, either precipitated by an infection or just per se. And there are also some idiopathic causes. In the UK, you can see from this that the biggest cause of meningococcus is from meningococcal C, and since the introduction of the meningococcal C vaccine, the incidence has reduced quite dramatically. But there are still other cases of meningococcus that can occur. I don't want to go into details about the septic shock and what occurs, but just to say that there is involvement of the pulmonary vascular circulation, cellular dysfunction, as well as myocardial effects. And my general treatment would be to try and improve tissue hypoxia and deal with myocardial depression that occurs from that. Specifically for Purpura Fulminans, you also will get changes in the microvascular circulation as determined by the previous speaker. There's also tissue necrosis, DIC, and acquired protein deficiency. So we would need to try and attack all these from all angles. So the general management strategies that I would want to do to improve circulation would be to just provide good intensive care. You need to minimize oxygen demands, maximize oxygen delivery, and treat the cause. So you should be able to do this in any of your units anywhere in the world. Again, early goal-directed therapy from the Rivers group showed that treatment early through very tight controls of CVP, mean arterial pressure, and the central venous oxygenation would improve therapy. And they showed that just by using very tight goal-directed therapy, there was an improvement in outcome with a big reduction in mortality, as well as a reduction in the need for vasopressors and ventilation. This led on to the surviving sepsis guidelines in pediatrics, and I don't expect you to be able to read this, but you would have had this in your day of knowledge yesterday. But just mainly to stress again that by 15 minutes, we would have expected you to be able to determine whether your patient is in fluid refractory shock or is fluid responsive. Cassillo's group showed that with pediatric shock, you frequently have severe hypovolemia, and that administration of more than 40 mils per kilo in the first hour, that is early goal-directed therapy, would result in a significant reduction in mortality. I would use colloid as my initial resuscitation fluid in sepsis, and again, the evidence for that is from the SAVE trial. I know this was done in adults, but they showed that the albumin group had a much less requirement for fluid and a much higher CVP. They also showed that there was no significant difference between the mortality and the days of ICU or the use of renal replacement therapy. But if you look at the subgroup analysis, the patients who had severe sepsis had a much better response with albumin, and they did better following resuscitation with albumin. So I think your strategy should be to first save the child, use early therapy, use goal-directed therapy, provide good intensive care, and again remembering, as Shane said, that mortality in children is usually associated with low cardiac output and not low SVR. So your aim would be to improve the cardiac output, which leads on to the next step of the guidelines. Your aim here would be to reverse septic shock, reverse the shock state, using different inotropes. Vasoconstrictors are suggested as to be used for catecholamine-resistant refractory shock when there's low SVR and low blood pressure. And the evidence for this is that vasopressin levels, you can see, is low in septic shock early on and much lower in the later stages of septic shock. So the evidence for this is that if you replace the vasopressin levels, it might improve. And vasopressin is a very potent vasoconstrictor that will improve organ perfusion. The reason for using it and its effect in the catecholamine-resistant shock is that it works via a non-catecholamine receptor B rather than the alpha and beta receptors. However, there is no randomized controlled trial for its use as a first-line inotrope, and I would use it only in the resistant situation. Vasopressin, as a very potent vasoconstrictor, might also lead to local systemic effects. You can see that quite often we also have invasive cardiac output monitoring, and that would reduce perfusion even further. But it comes back to the same strategy. Do you want to just save the limb, or do you want to save the child? And I think it's important, if you have a very low blood pressure, to use what you can to improve blood pressure, improve cardiac output to save the child. Steroids in sepsis. Anand's group showed that using low-dose steroids for 7 days, a combination of hydrocortisone and fludrocortisone, led to response in the steroid non-responders. And they had a much lower death rate in that group of patients, with additional lives saved for patients that were treated with steroids. Again, would you be using steroids in a septic patient? They found that there was no increase in adverse events, no increased risk of infection, and that they were able to reduce the vasopressors or stop the vasopressors in a bigger proportion of patients who were started on steroids. So again, in the refractory blood pressure patients, steroids would be your next line. Thompson reviewed the study and again suggested that there was no place for high-dose replacement steroids, but for low-dose replacement doses of hydrocortisone to replace the adrenal deficient patient. And those patients who were found to have cortisol deficiency were much more likely to respond to steroid therapy. Castillo's group, again in Archives of Diseases, reviewed the literature and found that there was a low cortisol ACTH ratio in non-survivors with meningococcal septic shock, and recommended stress dose steroids at 2 milligrams per kilo per day for the patients with catecholamine-resistant shock, and especially if there's adrenal insufficiency. And their recommendation was that if your back's against the wall, you have a patient who's not responding to all the inotropes that you're throwing at them, use hydrocortisone and in whatever dose that's necessary to restore homeostasis. In some patients with meningococcus, there may be adrenal insufficiency from Waterhouse-Friderichsen syndrome, and it may be what's required in that patient. But again, there are no trials of steroids in children. Continuing with the strategy of trying to save the child, there may be other adjunctive therapies that you can use. I won't be dealing with some of them because there will be sessions on IVIGs, and also Jan Hazelzet did something on GEM-CSF yesterday. We would use hemofiltration early, and we tend to use high volume, high flow hemofiltration. I'll show you the evidence for that later. The difficulties is trying to work out why it works in hemofiltration. Is it the effect of the anticoagulant that you've added to the circuit? Heparin has been suggested as being useful in patients with Purpura fulminans. Or is it the clearance of inflammatory mediators and the endotoxins by hemofiltration? We use hemofiltration early, again, because studies have shown that if you start hemofiltration before there's too much fluid overload, less than 5% compared to if they're more than 15% overloaded, you'll find that you'll get much better results. This was also shown in the Folan paper in critical care, where all the survivors had a much lower percentage of fluid overload, but this was much more significant in patients that had more than 3 organ dysfunction. So start hemofiltration early if you have the possibility of doing that. Also, try to use high-flow hemofiltration, because this was shown in the study from Cole et al. In intensive care medicine, where high-volume, high-flow hemofiltration, again, this is an adult study, so they were using volumes of 1 liter or 6 liters. The patients who were treated on 6 liters, high-flow, high-volume hemofiltration had a much greater reduction in norepinephrine use, and although when they tried to actually measure the catecholamines in the filtrate, it was negligible. Ronco's group, again, an adult study, showed that when he randomized the patients to 3 different groups using 20 mils per kilo low flow, which was their standard flow, and going up to higher flows, and they looked at endpoints of survival as well as when they stopped hemofiltration. They found, again, to reinforce the results from the other studies, that there were survivors in all 3 groups if the urea was low, that is, starting hemofiltration early before you go into established renal failure. But this was very good results, showing that the patients who were on the higher flow, higher volume filtration and higher volume filtration, ultrafiltration fraction rate had much better results than the patients who were on the lower flow. So what we tend to do would be to use 5 to 10 mils per kilo per minute of blood flow volume, and try to use anything from 10 to 30% ultrafiltration fraction. There was also evidence from animal studies to show, again, that using lower volumes and higher volumes achieved different results. And they also tested changing filters, because there is theory that some of the cytokines, endotoxins may be absorbed on the filters. And what they found here was that there were no survivors in the 2 groups, which clearly, if they were untreated, or also if they were on low-flow hemofiltration, but that there were better survivors in both the higher volume and as well as in the filter change. They were able to measure cytokines released in the filtrate, and they found that there was a lower TNF response, there was decrease in endotoxin levels, and it also led to downregulation of the MHC class 2 and CD14 expression. So that there was clear evidence that it affected the immunoparalysis that occurred in sepsis. What about plasma filtration? There was a trial that was done in Australia looking at adults and children, but unfortunately they consumed almost the whole Australian supply of plasma, and the trial had to be terminated before they recruited enough patients. But this showed a trend towards fewer organs failing and also towards lower mortality. The attempt to do a trial just in the pediatric patient unfortunately occurred around the same time as the APC trial, so it was very difficult to recruit sufficient patients for that because most were going into the APC trial because that was paid for while the plasma filtration trial was not. So we've not been able to achieve studies on plasma filtration, and the Australian group again commented that there further studies need to be done. There's no evidence that it works, but again, we would tend to use hemofiltration at high flows and high volumes, and that frequently would achieve some clearance and some improvement in the patient. In my institution, we are very fortunate in that we could at least, in the refractory shock patient, refer them on to ECMO. The ELSO database shows that there have been patients who are treated with ECMO for pediatric sepsis. In our own institution, the Lancet paper in 1997 showed 12 patients being treated with sepsis for meningococcus, of whom 6 survived. And looking at the Australian, Swedish, and UK data combined, there is about a total of 20 over patients referred for meningococcal sepsis with a 50 to 60% survival rate. It depends on the organism and the bug that's causing septic shock, and there are variable results with poorer results from staph and better results from meningococcus, and fantastic results with group B strep sepsis. So ECMO is an option that's available in some institutions. What about specific therapies? Can you affect the coagulation, since that's so affected in Purpura fulminans? Again, various people have tried different strategies, replacing clotting factors, replacing plasma, using anticoagulants to try and dissolve the clots, replacing protein C to normal levels, using fibrinolytics, and prostacyclin as an antiplatelet to reduce platelet aggregation. All these have been tried as anecdotal reports, but again, no large randomized studies. I'll talk about leeches at a later stage. But you've seen how Burnett's group in the APC study showed that protein C affects the thrombotic as well as the fibrinolytic pathway. It affects factor 5A and factor 8, and also leads to fibrinolysis. I won't go into the actual coagulation pathway because Jan Hazelset's already done a very good talk on that yesterday. But this was initially recommended as a short report, fast report in the Lancet by the Smith group. And they suggested that since there was severe acquired protein C deficiency, maybe if they could replace the levels to normal levels, you might get better results. And what they found, they tried it in 12 patients. None of the patients died, although the mortality would have been much more than that. And the 2 patients who actually needed to have limb amputations both received the heparin and the protein C late, compared to the others who did not need amputations. Protein C in the adult study showed that there was a big reduction in mortality and an absolute reduction in risk of death, as shown in this survival curve. But the studies in children have not been as promising, disappointingly. There was no difference in organ failure or in 28-day mortality, no difference in bleeding, except in the younger age group where there was an increased incidence of bleeds in patients who were less than 60 days old. And the pediatric trial was again terminated for lack of effect. So do I use activated protein C? Not at as the first line, but in some situations when your back's against the wall, possibly. The study also did subgroup analyses, and although the thrombin-antithrombin complex was found to be an independent predictor of mortality, there was no significant difference in amputation rate or in skin grafting rate in the patients with Purpura fulminans. So in a large randomized control study, no evidence that activated protein C works to save the limb. I have used leeches occasionally, on one occasion. The important thing to remember is that you have to use medicinal leeches, not something that you just go out and collect in your back garden. And you have to count them out, because once they've had a blood meal, they fall off the patient. And if you don't count them back in, they're then at liberty to attach again onto some other part of the patient or on the staff. So the reasons leeches work is that it has an anticoagulant. During the blood meal, it releases quite a few different chemicals in the saliva, into the patient, and it actually leads to inhibition of the platelet activation, vasodilatation, and increased permeability. I downloaded this from the leech website, where you can order your leeches from, and this shows you all the different chemicals that are released in leeches. So I've used it in Purpura fulminans on one patient with protein C, congenital protein C deficiency. What about other therapies that are available to you? Think about referring to the plastic surgeon early, because most of these patients could end up with compartment syndromes as well. And you may have to consider fasciotomies, because like in this patient where it wasn't considered at all, there was necrosis of the muscle, and this led on to wasting of the muscle. If you have an eschar that's encircling the limb, causing compartment syndrome, again, think about doing an escharotomy. So involve your plastic surgeons early. Hyperbaric oxygen has been used in some centers. I think Israel has a big experience with that. And Purpura fulminans is one of the recommendations or indications, accepted indications for the use of hyperbaric oxygen. The reason for that is that it increases tissue oxygenation, has an antimicrobial effect as well because of a reduction in bacterial killing. And it also reduces tissue edema because it causes vasoconstriction. The Israeli group have reported a few cases of its use in Purpura fulminans, leading to a reduction in the extent of amputation. I've not used it in the patients with Purpura fulminans, mainly because we have no pediatric facilities. There are mainly adult centers that run the hyperbaric chambers, and none of us are trained in the hyperbaric chamber use. Frequently, your patient would also be unstable, and it would not be a good idea transferring an unstable patient to a hyperbaric chamber. We would only use it in necrotizing fasciitis where there's more evidence that it works. So what I hope I've shown you is what I've done to improve the circulation, to save limbs, and to turn it from that situation to that where, despite the deep necrotic lesions, that the patient's just been left with some scarring. So what I hope you can take back to your units is to remember to first save the child. There's no point having a limb without a child that's alive at the end of it. Use early goal-directed therapy that you can all use in your units, and start off with aggressive fluid resuscitation, early respiratory support, and use whatever vasopressors is necessary to improve your blood pressure and improve cardiac output. Think about using adjunctive therapy if that's available to you. And the important thing is to avoid fluid overload and to start hemofiltration early. Unfortunately, there is no evidence that protein C works in reducing the amputation rate. And other experimental therapies may be available to use, but there is no evidence that it is effective. Thank you.